Отново благодариме на фирмата ЕЛТА за подкрепата на 90 за подкрепата на конференцията. Тя е наш главен спонсор. И накрая да поканим и представителите на Биомедика България, David from United Kingdom to present Lab Screen COVID Plus, which is a new diagnostic tool to protect transplant patients in the fight against COVID-19. Please, David, are you online?
I am. Can you hear me?
Hi, we can see you.
Oh, great. Can you hear me?
Yes, could you please speak a little bit louder?
Of course. Is that better?
Yes, thanks.
Thank you. I'll just share my screen now. There we go.
Okay, so perfect. Yes, we can see your presentation perfectly. Thank you.
That's great. Thank you. And thank you for giving me the opportunity to join you today to talk about a new assay that we've been busy developing for the last few months as part of the fight against COVID-19 and to help transplant patients. So some of the things that have come to light over the past few months during the COVID-19 pandemic is that transplant recipients, in particular, there are studies on renal transplant recipients, have shown that there's been an increase in mortality rate amongst these vulnerable individuals. So what we've identified as a risk is that the presence of antibody to COVID-19 and the titer of this antibody in transplant patients is a critical factor in risk assessment for transplant patients. Just to provide some background, previously I was HLA laboratory director in Liverpool, and at every time, this time of year, November, December, January, we would see significant changes in the HLA antibody profiles in our transplant recipients. And quite often these changes would be perhaps temporary, but would be quite marked. And often we could trace these changes in antibodies back to seasonal infections, seasonal viruses such as flu. So it makes logical sense in the midst of a global pandemic, as we are with COVID-19, that there is a risk to our transplant patients, that COVID-19 infection may actually impact upon the HLA antibody profiles of these patients and affect their chances of transplant. And indeed, in patients who are already transplanted, a COVID-19 infection has the potential to change that patient's antibody profile and perhaps put the health of the transplant at risk. So we embarked on an initiative to develop a COVID-19 antibody test specifically targeted at transplant patients. And to do this, we decided to run it on the LumenX platform, which we're very experienced in, but also to use multiple COVID-19 targets to increase the accuracy and the specificity of the assay. And just to provide some background, and I'm sure this would be familiar to many of you, there are so many authorized serological tests that have been developed very rapidly for COVID-19. And I'll talk a little bit more in a few moments about the specific targets that these assays and our assay look at. But quite often, they're just choosing one or two specific targets present on the viral nucleocapsid or the receptor binder. So often there's high chances of particularly false negatives in a lot of these assays. So basically, we entered into a research collaboration with Emory University, Stanford, University of Cincinnati, and University Health Network to develop a panel, to develop a LumenX-based microbead panel to really definitively identify antibodies against a defined set of SARS-CoV-2 or COVID-19 specific antigens. And we wanted to make this available to transplant patients. So this is where the lab screen COVID plus assay emerged. And as I mentioned earlier, as my background was in HLA as a laboratory director, I really felt that having this assay that could identify patients on our transplant list who had had a COVID-19 infection would really be powerful information for both the laboratory and the clinic, that we could use this to determine whether this infection impacts upon our patient's antibody profile. So as I've mentioned, one of the main features is that, and I'm going to talk a little bit more about this, is that there's multiple antibody detection targets on the panel. And when I explained that there are a number of targets on the panel specific for common cold viruses and things like MERS and the original strain of SARS, you can see that it's really specific for COVID-19. So a lot of the cross-reactivity that we see in other tests with common cold viruses can be eliminated using this assay. And to me, when we think of this assay and we think of its application to transplant patients, this is the most important benefit, I think, that we can actually link COVID-19 infections to changes in HLA antibody profiles, so that we'll be able to manage transplant patients more effectively, particularly through the pandemic. And on a technical level, it's been designed so that you can run the COVID-19 panel in association with the standard HLA panels that transplant laboratories are already very familiar with. So this is a little bit more detail now about the actual target that the targets that are present on this screening panel. So this is the viral nucleocapsid and spike diagram. And you can see on the receptor binding domain of COVID, there are two spike proteins, spike protein 1 and spike protein 2. And on our panel, in addition to a negative and positive control, we've got 5 different beads that are specific for different regions of the RBD and the spike protein in particular, but also the nucleocapsid protein. So you'll remember from a few slides back, some of the other assays on the market would be looking maybe just at the spike or just at the nucleocapsid. And this is important because there's been a few papers that have emerged recently that shows that patients developing antibodies to different parts of the virus itself actually impacts upon survival and mortality. So patients who actually form antibodies against the nucleocapsid protein rather than or in addition to the spike have a much higher rate of mortality. So there is a sort of a clinical significance to knowing which parts of the viral protein your antibody is directed against, and that's covered on this panel. There are also a range of common cold coronaviruses that are present on the panel as well. So there's often cross-reactivity when many of us have been infected with common cold virus in the past. This is what can potentially give rise to false positives in some of the COVID-19 specific assays on the market. And there are also a couple of beads on the panel there that cover previous MERS and SARS acute respiratory syndrome viruses. So we're trying to really distinguish between this year's pandemic producing virus and those of years gone by. The protocol, if you're familiar with HLA laboratory workflows and HLA antibody tests, you'll see that the COVID plus protocol is very similar. It's a simple mix of human serum and beads, followed by washes, and then a detection with anti-human IgG, which is PE conjugated. If you're interested, you could swap this out and look at IgM, IgA, or any other immunoglobulin. And then it's read on standard Luminex instrumentation, so an LX200 or an LX3D, which are throughout all HLA labs. And this takes typically 2 to 3 hours. So it's a fairly rapid assay to carry out. And in the time remaining, I'll just run through 2 or 3 individual case studies of some actual samples that were run on the assay. So this is the first case, which is actually strongly positive against all SARS-2 viruses. And it's we've reported over 99% specificity in the assay. There's a paper that is published this week in Transplantation by the team that developed the assay and collaborators. So it is highly specific, this assay. So this is a case that shows a patient who is strongly positive to all of the SARS-CoV-2 targets. So positive against spike 1, spike 2, but also importantly, the nucleocapsid. In case 2, you can see that this is a case in an individual that is positive against specific parts, so strongly positive against the spike protein in general, but actually much less positive against the spike S1, the spike RBD, and actually negative against spike 2 and the nucleocapsid protein. So it's very different to case 1, and it's something that you can assess and use this data in a different way. And this is case 3, and this is probably many of us would probably give a result that would look like this, that you're negative against the SARS-CoV-2 virus, so COVID-19 negative, but very strongly positive against other seasonal common cold viruses. So I would imagine if we were all to be tested, many of us would probably provide a similar profile to the one you see here. So I'll just summarize with just a few points that, again, we identified the risk to our patients, our transplant patients, of a COVID-19 infection, the increased mortality. But what we'd like to, and what we have done, is we've developed a test which we think is able to give a deeper understanding as to the nature of the infection in our transplant patients. Having this deeper panel of antigens, having the antigens specific for other common cold coronaviruses and other respiratory syndromes really helps us to feel a lot more confident about correctly calling a COVID-19 positive. And that's all to do with the ability to multiplex on the panel. And I think for me, as somebody who was the director of a HLA lab, to actually be able to distinguish between transplant patients who have had a genuine COVID-19 infection and those who haven't will allow us to better manage them, and to test alongside HLA antibodies will really enable us to show whether there is an impact of COVID-19 on HLA antibody profiles. And if so, what does it mean? And I think as we use this and as this is used by laboratories, we'll get some real information as to how long perhaps these antibodies persist post-infection. Do the antibodies that patients produce in response to COVID-19, do they stick around like we know HLA antibodies can for many, many years? So it will be interesting to know. And this could offer insights into things like vaccine development, where we're looking to induce antibody responses. So anything we can learn about the sort of duration of the antibody response to COVID-19 is of great value. I'll just kind of finish with, there was a webinar which did take place in August, and it's from the group that we worked with to develop the assay. And it's a really nice webinar which provides a lot more sort of in-depth information as to the performance of the assay and the applications clinically of the assay. This can be accessed at any time via our website as well. So if that is of interest, I think that's a really worthwhile. It's a really worthwhile lecture to listen to. And I'll finish there if that's okay, and I'll be very happy to take any questions.
Thank you so much.
You're welcome.
For this presentation. I'm sure that this assay, Luminex-based precise detecting of specific antibodies, will have even broader application than these risk groups of transplanted patients or those who are waiting for transplantation. It's very important to monitor them as well. And I'm very pretty sure that even in our department we'll start to do this along with the antibody screening with the same platform and the same hand-to-hand with these two protocols. So thank you very much for this good information, and that you has focused your attempts to this risk group, to these vulnerable patients, which are more or less more threatened by this infection than the other individuals. So please, do you have any questions from the whole? If not, I'm sure that your presentation reached many of our participants which are online now. So hopefully, yes, there will be further discussions. And thank you so much once again for your participation and support to our conference, and stay safe.
And you.
Thank you so much.
Thank you. Thank you very much. Bye.
Bye-bye. И отново, колеги, да благодарим на фирмата Биомедика, която е спонсор на нашата конференция, един от спонсорите на нашата конференция, за подкрепата и приноса, и за това, че винаги така е в крачка с потребностите, имунологичната диагностика и практика. И с това приключваме сесията за презентациите, които са подкрепени от нашите спонсори. И в 14 часа, след около 12 минути, започва втората сесия, която ще е посветена на автоимунитет и автоимунни заболявания.